With regard to combinations of immunotherapy with conventional treatments, such as chemotherapy for patients without a driver mutation or patients with a driver mutation who would otherwise get a targeted therapy, how optimistic are you about concurrent treatment versus sequential? Do you think there's a good reason to favor a concurrent approach versus thinking that you would do just as well or better by just sequencing these independently? Leora?
So I'm not a big fan of the concurrent with chemotherapy trials. There has been data presented a couple times showing that patients maybe have a greater response, but I actually question whether some patients even needed to get chemotherapy to begin with. And a lot of the trials, I worry, are comparing chemo with or without immunotherapy, but there's no arm that's immunotherapy alone. And so are you just getting the responses that you would have seen with immunotherapy if you had just used that up front? And there are a little bit more toxicities when you're looking at these combination trials.
What are your thoughts, Ben?
Yeah, look, I think it's still early. I think we had some encouraging data, although just with respect to response rate, about the combinations of platinum doublets with PD-L1 inhibitors. I think Ross Camage presented a study where, in a very small number of patients, the response rate with the combination seemed to be above 60%, which we would think would be higher than expected with chemotherapy, and I thought that was encouraging. Whether it made any the sequence made any difference, I think remains to be seen. In that particular study, toxicities didn't seem to be a big issue, but I think they're early days, and I think patients may well respond to immunotherapy alone. And I think a question will be sorting out which patients can be treated with immunotherapy alone and which patients won't respond and do need combinations either with immunotherapy, with other immunotherapy agents or with chemotherapy.
Right. One of the concepts is that perhaps the cell kill from chemotherapy or a targeted therapy can lead to greater immunosensitivity, kind of prime the system and lead to more robust immune responses. It's something that hasn't been tested, really. I would say that as we had started to discuss, it's a pretty broad approach to clinical trials with immunotherapy, which is basically alone or in combination with everything in every setting of every cancer. And if there's any upside of that, it's that these will all be tested in the light of day. We'll see what the data show. Right now, we're pretty devoid of data and just speculating, but in a couple of years, we'll actually have data to compare and make some intelligent recommendations.